over to you, Dr. Brice.
Lovely. Thank you very much, Lydia, and hello and welcome everybody. Thank you for your time this evening. Perhaps I should just very briefly explain what the PHG Foundation is for those of you who don't know. We're a policy think tank that's also a charity of the School of Clinical Medicine here. And we're concerned with making science work for health, and in particular making genomics work for health and genomics and related technologies. And particularly making genomics work for public and population health. We've been going for nearly 25 years now. Our founder, Dr. Ron Zimmerman, founded us as the first Centre for Public Health Genomics in the UK. And we've been working ever since with a multidisciplinary team. So we cover science and the humanities, law, regulation, medicine, public health in all our work. And much of the work that we do around supporting policy and clinical implementation of science, it's absolutely essential that we work with experts in medicine and public health, other policy organisations and so on. So it's a real pleasure and a privilege to be invited to moderate such an all-star panel for you this evening of experts who have all individually made quite exceptional contributions to genomics and public health in recent years. So for those of you who might not be aware, we have with us today Professor Dame Sally Davies, who is UK Special Envoy for Antimicrobial Resistance and former Chief Medical Officer for England, as well as Master of Trinity College, Cambridge, which I assume you are there now, Dame Sally?
Yes.
We have Professor Sharon Peacock, Executive Director and Chair of the COVID-19 Genomics UK consortium, about which we've all heard a great deal in recent months, and also Professor of Public Health and Microbiology in the Department of Medicine here. And last but very much not least, Professor Paul Pharoah, who's the Professor of Cancer Epidemiology and Director of Teaching at the Department of Public Health and Primary Care here. So the weight of your knowledge is making me feel quite daunted, but let's start a conversation. So could I begin with you, Dame Sally? I know you've had a long-standing interest in genomics, among much else, and during your time as Chief Medical Officer, it was one of your CMO annual reports called Generation Genome, which really paved the way for the current UK National Genomic Healthcare Strategy, which was launched in the autumn. I wondered if you could say anything about what made you see genomics as being important for public health as well as clinical care.
Thank you very much. It's lovely to be here and great that you're moderating this, Philippa. So you have to go much further back and understand where I came from. My specialty was sickle cell disease, the paradigm molecular disease. And I faced, both in my training, then as the first specific sickle cell consultant in the country with 600 patients in my clinic, the issues of genomic exceptionalism. There is no genomic exceptionalism. We look at a protein in the red blood cell, we find sickle and we know what the gene is and we know what the patient has. I faced the issues of antenatal counselling. I faced all of these difficult issues and grappled with them over the years, debating with my sickle cell specialist nurses and our public, our patients, what was the right thing, what should we do, how should we make it work? So then when I became CMO in, I should know when, shouldn't I, 2010, I had to write an independent annual report every year. It's statutory, and I could choose what I did. So I chose to do a series of subjects which I was interested in, I felt were Cinderella, and I felt that if we really focused on them, we should be able to move the subject forward. And the way I did it would be to choose the subject, get real experts who I knew and trusted in. We would talk about it, they would write their chapters. I'd have a public health registrar helping, editing, and then we would write, so what does this mean for policy? And it was all backed up by these wonderful chapters. So Generation Genome, I didn't want to do too early, but I didn't want to leave too late. And I got it out, and I could probably look, but it was about 4 years ago. And we made sure that most of the recommendations stuck. A lot happened at the time, and more are just gently coming through and happening. It's very interesting how long it takes to shift policy and get some of the ideas from annual reports and policy documents to be in everyone's heads, so that then they just do it without thinking where it came from. But why does it matter? Because it's a technology. Genomics is a technology that tells us so much, and we are bonkers if we don't use it in pursuit of improving outcomes for our patients as individuals and our public as a population. And I'm very keen, and I'm delighted Sharon's here, on, you know, genomics of bugs, looking for what it is, the strain, and AMR. I can see all the myriad of opportunities, and I wanted to open those up. But we've got two experts to open it up, so I'll hand back to you.
Lovely. Thank you very much indeed. So yes, Sharon, if we could come to you next. I think very clearly anyone who is in any doubt about the importance of genomics for infectious disease control a year ago has now seen the light and realised that it's very important. And in fact, the COG-UK has been an incredible demonstration of what can be done with the UK strengths in genomics. But I know you've been pioneering this field for much longer than that. What made you realise the potential of genomics for infectious disease?
Well, like Sally, I've kind of got particular dates just to go through, just to help you understand how I ended up doing what I do. So I've been living in Thailand for 7 years, working at the Welcome Unit in Bangkok. And I was really studying diseases of the rural poor there, leptospirosis, rickettsial infections, melioidosis. And I had 3 children, and we were transitioning back to the UK. And at the time I was thinking, it's 2009, what am I going to do in terms of my science? Because it wasn't very transferable. You know, we don't have a lot of the sorts of diseases I was dealing with in Thailand in this country. So I looked at what was really up and coming, really innovative. And it was quite clear to me that sequencing was an incredible innovation. It wasn't just that you could use the technology, but it was really a turning point in around 2010 when benchtop instruments became available on the market. Now, what that meant was you could have a machine about the size of a cappuccino machine that could do pathogen sequences, and it could do them fast, and it could do them relatively cheaply. So back in 2001, a genome of E. coli, bacterium that lives in your gut, would cost £500,000, and it would take 18 months to do just one. Actually, by the time I was returning from Thailand, I could do many genomes in a day, and it would cost about £100 to £150 each. So the technology revolution was what really set this off. So many of us actually started to invest in that type of science, looking at what we could do to understand areas of pathogen biology, including AMR, transmission, many different areas actually, and it really took off then. I think another point in the history actually was that in 2013, there was the 100,000 genome project, which actually Sally was instrumental in developing and launching. And at the time, there were 3 working groups, one to consider applications in cancer, the second in rare diseases, and the third in pathogens. Now, the pathogens perhaps didn't get quite as much sort of headlines at the time, but back in 2013, a group of us got together to say, how can you use sequencing for public health benefits? And at that time, our top recommendation was that the UK should sequence TB, the organism that causes TB, Mycobacterium tuberculosis, as a matter of routine to detect multi-drug resistance as soon as possible, and also to help with transmission tracking. So the UK became a leader then in terms of being one of the first to start doing routine TB sequencing. And so that was a really important landmark for me. generation genome that we've heard about from Sally was really key for me. I led the writing of a chapter on pathogen sequencing, and that really set out everything we could do at that point with sequencing, and we described the uses. And we were also thinking about, well, it had been used in West Africa during the Ebola outbreak. So by the time we got to the early part of last year, many of us, and there's a large community of people who have fantastic expertise in pathogen sequencing, realized that this was the moment that we really use sequencing to help support public health decisions and public health interventions. At the time, it was a bit of a risk because, well, it was a big risk actually, because it had never been done before on such a scale and in real time. But that collective history actually really came together in many people's minds. And we simply decided that now was the time to use sequencing for best effect and as part of the control measures for COVID-19. So it's quite a long history, and it involves quite a few people with key points in that history, but that's really how it happened. And that's the beginning of our story, our second story.
Yeah, thank you very much. Yeah, lots to think about there. And if I could perhaps come to you next, Paul, move from one huge public health burden to another, over to cancer. I know your work's really driven fairly fundamental improvements in the understanding of genetic influences on risk of cancer. How do you feel the role of genomics in public health approaches to cancer has developed over the years?
Sort of when I was thinking, as I was primed that this was going to be the first question, when I was thinking about this beforehand, my immediate thought was, well, it depends on what you mean by public health, and it depends on what you mean by genomics. These are sort of defining things. And I think cancer in many ways is an interesting disease because it's fundamentally a genomically driven disease, in that it's the genetics of the cancer cells which determine the characteristics of the cancer. And so people have been interested in cancer genetics as a somatic, whether it's the genetics of the cancer that we're interested in, for very many years. And so the genomics revolution, cancer was already primed to make the most of that. And a lot of what we hear about personalized medicine in cancer has been driven by cancer genomics. And so that's involved sequencing cancer genomes, i.e. genomes in cancer cells. More broadly, beyond just the genetic part of it, there's been lots of work on gene expression and how that influences cancer behavior and response to treatment and so on. And then kind of newer areas of genomics, like epigenomics, becoming very interesting. However, having said all of that, that's, as you know, Philippa, not really been my area of interest, because my research has been focused on inherited genetics. And as you know, when the PHG Foundation started out, the G stood for genetics, not genomics. And kind of traditionally, genetics meant inherited things. And I suppose my interest has been around genomics or inherited genetics and what the public health implications of that are. And as with both the story that Sharon told and the story that Dame Sally told, this has kind of got a long history. I started doing this work in the late 1990s. I wrote what I always regard as my best paper in 2002. It's been downhill from there, folks. Around the potential for polygenic risk scores in stratified cancer prevention. And this has been an idea that has taken quite a long time to really receive any traction, and it still isn't really part of kind of everyday NHS practice. But in the last few years, it's really, I think, people have started to take more notice of it, and the potential for stratified prevention is becoming more apparent. But it's still, despite me writing this paper nearly 20 years ago, it's still kind of early days in the inherited genomics, if you like. But the somatic genomics, extremely well developed in cancer. And most of what people hear about personalized cancer medicine is around the somatic genomics.
Yeah, thank you. That's a really helpful overview as well as insightful. Yeah, I wonder now if I might move to putting some questions to the panel as a whole, and you can respond as you prefer. We want to start by having a think about how genomics is currently being used in the NHS in this country, which we sort of touched on in a number of respects, but perhaps we could dig a little deeper to highlight the areas of particular importance. Do I need to pick on individuals?
I think you do. Yes, go on.
All right, let's start with you then, Dame Sally.
That was silly of me, wasn't it?
Yes, it was.
We've been doing genomics in a number of areas forever, as in one way or another. I mean, I'm a hematologist, so the Philadelphia chromosome of CML, that I guess Paul now knows much more than I do about, you know, we were looking at chromosome changes and then taking them to the genomic level, because we began to learn that the change told us something about the outcomes. It linked to whether you needed to have really aggressive treatment or less aggressive treatment. And then if you go from that to the fact that clinical geneticists have for years been trying to determine what was going on with essentially what we now call the rare diseases, they were doing all sorts of biochemical tests, electromyography, EEGs, all sorts of things. But once genomics came, they were able to do much more. And then, of course, Sharon will talk to the bacteriology. So I think it started slowly. But what we've needed to do, and in fact, I do think that the 100,000 Genome Project really moved this forwards, was to move it much more routine. And I talk about democratizing genomics, because genomics should not be the province of clinical geneticists. It has to be the province of everyone who's looking after patients or doing public health. And what the 100,000 Genome Project did was, as you've heard, pick three big areas: infection, rare diseases, and cancers, and start particularly strongly in the rare diseases, offering whole genome scans. And that has revolutionized the diagnosis and, on occasions, the treatments of inherited rare diseases, which, of course, when you look at the prevalence of all rare diseases, are not that rare. And that's led to a lot of work. For instance, the NHS Genomic Medicine Service that Sue Hill set up, the testing manual, because we all have a view that if we can do things, then it should be available to patients and the health service wherever in England that it can be. So I think to talk about the Genomic Medicine Service and the testing manual are terribly important, but they came directly out of that 100,000 whole genomes project.
Yeah, thank you. So making sure there's sort of fair access to this excellence across the country is quite a big step forward. I know in the past, you're much better served somewhere like Cambridge or Oxford that's full of experts than you were in other parts of the country. So it's going to be great to see what a national genomic medicine service can really do to address that. Thank you. Paul, I wondered if you might say anything about where we might be headed next with polygenic risk scores for the future.
Sure. So perhaps for this audience, I should explain what polygenic risk scores are. So we know that for cancer, in fact, for most human traits, human phenotypes, the underlying genetic precedents are complex, and there's hundreds or thousands of places in the human genome where genetic variation will influence that phenotype or trait. And so, for example, in breast cancer, we have identified over the last 20 years hundreds of so-called single nucleotide polymorphisms. So they're placed one individual's genotype can vary from with small differences in risk of breast cancer. And while any one of those has no clinical impact, if you take the hundreds, you can put them together into a so-called polygenic risk score. So effectively what you do is you measure genotype at hundreds of these variants, and then based on that genotype, you can come up with a range of risks such that in the population, the risk is distributed along the sort of classic bell curve or normal distribution. So you have some people who are at high risk, some people who are at low risk, and lots of people in the middle. And so people have started kind of combining these polygenic risk scores with other risk factors to come up with comprehensive risk models, and then they can be used to stratify the population and think about personalized prevention. And in the context of cancer, what that really means is personalized screening programs. So in breast cancer, there is a National Health Service screening program. We have national screening programs for colorectal cancer, for cervical cancer. And the possibility is that you could identify people according to their level of risk and offer them more personal screening programs depending on the level of risk. And there are trials going on. So I'm involved, for example, in a European-wide trial funded by the EU, very large trial where we're randomizing 80,000 women to either have a polygenic risk score and then a personalized screening intervention, or to have standard current screening according to their national program in different European countries. So polygenic risk scores just about getting to the place where they could be used in clinical practice, but quite a lot of research still needs to be done.
But one to watch for the future?
Yeah, of course, you don't know what the results of the trials are going to be. It's actually very, very difficult because screening trials of whatever X-ray mammography for breast cancer or for prostate-specific antigen for prostate cancer or endoscopy for colorectal cancer, to do those trials, you need very large studies. They cost a lot. They take many years to do because you screen people for many years to get the benefit. And so to have trials of stratified screening are even more difficult because you're adding another layer of complexity on. And so while there's a lot of promise, I think there's a lot of work that needs to be done just because it's so difficult to do it. And we don't really know yet how well it's going to work. There's a sort of allied bit to that that's not really about the genomics, but technology for cancer detection and earlier detection is also developing very rapidly. Imaging methods, nothing to do with genomics. And so it may be that in 5 or 10 years' time, as some of these new modalities of cancer detection come along, we'll have to do trials in combination with polygenic risk scores to show that they may or may not be useful as screening modalities. But that's a sort of slightly longer term future.
Very interesting, though. Yeah, lots of things going on in cancer. Thank you, Paul. I wonder if we could come to you next, Sharon, to perhaps talk a little bit about the work that you've been leading in the COG-UK, thinking about other large-scale research and where where you've got to so far and where you think that might be headed next, perhaps?
So, so COG-UK is a consortium which contains around 400 people, and we have 16 different sequencing labs, plus the Wellcome Sanger Institute. So there's the four public health agencies of the United Kingdom, 12 academic laboratories based in universities that do sequencing, and then the Sanger. And so the way that we work is that we aim to do as unbiased sequencing of SARS-CoV-2 as we can, with broad coverage across the UK, because this variant will, this virus will continue to mutate, and we need to be able to have eyes on the virus across the country. So we sequence the virus from people who are in hospital, that's pillar 1 testing. So we connect with more than 100 different NHS laboratories to do that. And we also sequence viruses from people who in the community are not unwell enough to go to hospital. And that goes through the Lighthouse Lab. So that's pillar 2 testing. And so we sequence at the moment around about 20 to 22,000 viruses a week. So just to contextualize that, the year before the pandemic, Public Health England is very good at sequencing. They sequence 50,000 in a year. So we're doing about that in 2 weeks at the moment. Now, we need to do this because we need to understand the evolution of the virus, and in particular, whether it's developing mutations that lead to vaccine escape, immunity escape. And there are some variants of concern that are arising at the moment. So we've only fairly recently, since really November, seen a burst of evolution in which the virus has begun to change through natural selection. And we've seen all around the world, actually, particular mutations arising that are in the same place in the genome that lead to potentially or partial vaccine escape. We've also seen variants in this country that are particularly transmissible. So what we do is we have eyes on the virus every day. We sequenced around 340,000 viruses so far. It's about half the world's total. And our job is to provide public health agencies with the information so they can track where the variants are, where they're being introduced, where they're actually emerging, because variants will actually arise in this country as well as elsewhere. It's happening all over the world, so that people can track them and then track the pandemic. And in particular, that's useful because over time we will be looking to tweak the vaccines. So I think it's almost inevitable now, the place that we are at the moment, that we'll need to adapt the vaccines and tweak the vaccines so that we can give them against the new variants as they arise. So sequencing is going to be really a long-term partner to vaccine development and vaccine rollout, and really control of the pandemic as we go into the next few years. So we're just going to have to keep sequencing the virus until really, there could be a day when it's no worse than the common cold, but all the while we need to vaccinate against it, we'll need the sequence data. So looking ahead, we're going to be sequencing SARS-CoV-2, but it's also at the ready for many other threats, and that includes new emerging pathogens. And so I'm not the first person to say that another emerging pathogen is not a question of if it emerges, but when. And sequencing is a very quick way of working out what that's usually a virus, actually, working out what that virus is, where it is, and so on. And so if we look ahead, sequencing has many different uses, including in antimicrobial resistance, but it could also play a key role in a future pandemic in the event that a new pathogen emerges. So yes, it's we're not going to be out of a job for a while yet.
No, indeed, thank you. And I was reading that somewhere recently that with the effects of climate change, actually it was probably from the World Health Organization, that the circumstances which can give rise to new pathogens are sort of only tending to increase. So I think it's really important that we as a country build on your successes and also around the world, which perhaps leads me nicely into another question. Although I should just say, for the benefit of the audience, if you want to start submitting questions through the chat function, we are going to have time to address some of those questions before we finish. So start popping them in there while we're talking, and we'll take them one by one. I just wanted to ask all the panel really on their perspectives about what they see as the most important or pressing issues around issues of genomic data sharing. That could mean obviously nationally and internationally, because of course it has relevance to all the areas that we've touched on, and it's quite an active area.
So why don't I start? I think there are two things. One is trust and the other is privacy. So I sat on the World Health Organization Executive Board for 3 years and everything. And of course, if you look at the wonderful work that Sharon's doing, it needs sharing across the world. Do we need to trust the data? Yes. Do the people who happen to have those bugs need to trust it? Well, yes, in quality, because their outcomes may depend on that. But it's, for them, the issue is privacy. And of course, it is totally private because it's not labeled with for the patient. So we can share it and we can see how it's going round. But when you get to something like the rare diseases in the 100,000 project, privacy and trust in how the data will be looked after is terrifically important. And how do you handle it? And people take quite different views. We, for that, led by Viv Parry, who's fantastic, as you will know, at bringing in patients, parents, families, did do a consent to share the data as needed for the benefit of that individual and of others, but all anonymized. And then the other thing we did, and I think people are doing this more and more, was we kept all that data within the NHS firewall. So if people wanted to use it, they had to come into our Genomics PLC database, and they had to have permission, they had to have training, and we could audit what they were doing and make sure that it was proper. And they only took the results out, not the patient data. But it is about trust and privacy that we have the debates.
So perhaps I can pick up on a slightly different note, and I completely agree that trust and privacy is really key. Actually, I think that COVID-19 has been an exemplar in terms of sharing data. So we certainly share all of our genomes as soon as they're generated. And often scientists will want to keep their genome data so they can analyze it and write a nice paper. Actually, people have been incredibly excellent in terms of open science attitudes. So everything gets put immediately into a global database called GISAID, where all of the SARS-CoV-2 genomes sit and can be analyzed by anybody. And I think that, so it has been a really important lesson on how we can share, together with methods, protocols, data analysis, methodology. Everything gets given away. It's very much a giveaway culture. I think that the two other problems we face, though, one is there's not enough data generation. And so, unfortunately, there are parts of the world who don't have the expertise, the know-how, or the funding to do sequencing. And that is a clear inequity. So there's inequity of vaccine availability. There is an inequity in sequencing, and the two do go together. And so if you're going to vaccinate a population, particularly as we go into the pandemic further in, when more variants are around, you're going to really want to know if a particular variant is prevalent. And to vaccinate without that information could mean that the vaccine is not as effective, or the vaccine strategy is not as effective. And so supporting the world to develop sequencing capabilities is going to be so important and critical. But the second problem is data analysis. And so analyzing these data, is not necessarily straightforward when there's a large amount of data. And so we very much need to focus on where we store the data and how we analyze the data to make it completely understandable to people in a way that they can act. And so that you don't have many hundreds of informaticians required in order to make sense of the data around the world. So I would say data generation and data analysis will be the things that we'll be facing as we go forward in this pandemic and beyond.
Thanks very much indeed, Sharon. That's really helpful. Paul, do you find, I know from my legal colleagues, legal and regulatory colleagues, that data sharing between countries for large-scale genomic research projects isn't always as easy as it might be. And even within the country, although I think we've made progress there, it isn't always as good as it might be. Is that something you think we need to improve on? Do we need to get better at our global genomic data sharing?
I think there's a big difference in data sharing between sharing data that's been kind of primarily generated as part of research projects, which in cancer genetics and the world I'm in is what it's mainly been. And as this transitions into sort of routine clinical practice and the generation of data and genomic data as part of the NHS, and I think they have, slightly different problems. I mean, how you use NHS data and how you make the most use of that data, I think is important. And I mean, the 100,000 Genomes Project was, in a sense, a sort of way of saying, well, actually, we can do this sort of thing in the NHS and make the data available for research, because that's sort of fundamentally what you want to do. But actually, if we're really going to make this useful in the future, it's the annotation and how you curate all those data and actually make it useful from a research perspective that's important. Because you can sequence cancer genomes, but if you can't link that sequencing data to drug therapy data and clinical outcome data and other pathology data, then the research questions you can ask are limited. And so taking all of what Sally says about trust and privacy, that's incredibly important, but you also now need this sort of massive bioinformatics infrastructure, which is, I think, what Sharon was sort of alluding to actually really make the most of these data. And I think we need to be careful that we don't just start sort of creating massive kind of oceans of data that actually they don't have any really useful purpose because they're not properly linked and usefully linked. We've got some examples in cancer that I kind of wanted to mention. So, for example, in Cambridge, there's a program called the Personal Breast Cancer Program. And this is the idea of trying to sort of take every new woman with a new breast cancer diagnosed to do comprehensive genomic profiling as sort of part of their routine care. So it's still really research because it's not sort of standard in the NHS, but it's rooting this in NHS practice. And so this has all been about, right, we're going to generate all this genomic data and we're going to have these genomic data stored and available for analysis. But that's just in one center with kind of relatively lots of resource. How you kind of extend that and make it NHS wide and then potentially worldwide, I don't know. It's potentially very exciting that so much data is there, but also rather daunting. I mean, one of the questions on the chat is, will biologists need to familiarize themselves with machine learning and AI? I mean, I don't think the details of the methods matter, but the opportunities will certainly be for people with good understanding of quantitative data science, without it necessarily having to be what might be labeled as AI, is going to be incredibly important in the future.
Yes, and that leads in, that was a good question. It leads into part of one of the other questions. There's some really good ones here about how Max has said, how do we hope genomic medicine will integrate with clinical care in the future? And will it operate similarly to a pathology service? I think there's some interesting questions there with the sort of evolving role of different and perhaps new specialists within the NHS to help do this.
Maybe I can comment on that with respect to the personalised breast cancer programme, because that's exactly...
It's a great example.
You know, a very good example, because as, you know, when a woman has had a diagnosis of breast cancer, then we sequence the genome of that tumour, and part of the process of kind of mainstreaming this is to then make the results of that whole genome sequencing available to the clinicians treating the patients. Now, obviously, that's kind of specialized data, and turning whole genome sequencing data into sort of bits of information that might be clinically useful is a challenge. And that's part of what the personalized breast cancer program is investigating. But in a sense, it is operating like a pathology service. The sample goes in, and a summary of the results of what you do is then made available to the clinician. You know, the clinician doesn't need to be an expert cancer geneticist. They are given at some level some interpretation, in the same way that currently an oncologist does not need to be a specialist pathologist when they get told details of the breast cancer pathology. So in some senses, yes, it would be like the way the pathology service is run, or even, you know, in days gone by, clinical biochemistry was a much more complicated, or apparently complicated area, whereas now, you know, clinicians, they just send off blood tests and they get the results back, and they don't need a clinical biochemist to interpret them anymore. They just becomes part of the routine.
Yeah, so some things operating at routine and some things needing sort of expert interpretation for more generalist clinicians. There's a really good question that's come through on the email, bit of a killer one this. Can you provide any examples of where genomics has had a measurable impact on population health? For example, increase in life expectancy or a measurable reduction in all-cause mortality?
It's pretty hard to identify anything apart from immunization that's had a measurable impact on population health in terms of medical interventions. You know, because actually so much of what we do is incremental, and you have lots of very, very small effects, and it adds up to increases in life expectancy. But pinning any one intervention on those increases, and the things that have the biggest effect historically have been major infectious diseases and kind of child and maternal mortality. So when it comes to genomic medicine, I think Sharon could probably give you some better examples related to COVID-19, but they are in the infectious disease field. But other than that, I think it's very difficult.
I'm really keen to answer this one. So there are measurable impacts from pathogen sequencing. So the first sequence of SARS-CoV-2 was completed by the middle of January, and that was completely instrumental, actually, in developing vaccinations for COVID-19. Without that, it would have been much more challenging and would have taken much, much longer. So that's what one example. Another example is that we routinely sequence the HIV virus in patients who have a HIV infection. Now, we do that as part of kind of personalized medicine, and what we're doing is looking for mutations in the virus that could indicate resistance to the drugs that they're taking, but also to find what we call minor variants, which are variants that may be a very low proportion of the population, but that actually have mutations that mean that they're resistant to the drug, because if you apply that drug, it will select out the resistant variant. So personalized medicine is already here with pathogen sequencing, together with TB, a very quick way of finding out if something is multi-drug resistant, much faster than standard laboratory tests, is to sequence the organism. And so again, another example of where you can get the patient on the right treatment. So we've had vaccines, we've had personalized treatment and directed treatment. Going forward with COVID-19, We all need sequencing to keep our vaccines effective and up to date. But another example, a final example I would propose is a public health application of sequencing, and that is for outbreaks. So particularly foodborne associated outbreaks. So before the pandemic came along, I think it was probably around the middle or end of 2019, you might remember that there was a listeria outbreak in the country that was associated with food that had been provided to hospitalized patients. And actually listeria, it's usually pretty harmless if you're immunocompetent, but if you're either pregnant or immunocompromised, then actually the disease can be very serious indeed. Now, the first time that it was realized that there was an outbreak was actually because we routinely sequence listeria and compare isolates as the genetic information comes along. And that was the very first indication of a listeria outbreak involving hospital food. Now, it was impossible to detect any other way because the first few cases were in very geographically dispersed hospitals, where just one case in the course of a month wouldn't have raised an eyebrow. But actually, when you've got cases that are linked by genomics, you then send out your team to investigate. And indeed, the listeria was in the food preparation factory that was actually assembling the sandwiches and sending these out to hospitals. And so I've always said to Sally, actually, that pathogen sequencing is you can demonstrate real value in doing this. It's relatively easy to do because, of course, the genomes are very small. But if you add all of that up, and that's just actually a few examples, if you add all of that up, then pathogen sequencing has already made a clear difference to human health and could actually be counted. And I could give you other examples as well, but there is a very clear and demonstrable effect on human health from doing what we do.
Sorry. Did you want to say anything else on that issue, Sally, or shall I move on to some of the other questions?
I keep moving on.
There's an excellent one here from Lauren, who has done a master's in genomic medicine and is a midwife by training. Good on you, Lauren. That's certainly more than I've ever done. And she's interested in where genomics might be developing in the NHS, where perhaps she should be looking to stay involved in genomics. Any advice there? I know we had a whole top hole review on possible directions for genomics and training among health professionals in genomics.
So I'll make two suggestions where it may come in. I think that we ought to look at the value of whole genomes for neonatal screening rather than the present biochemical routes. And I think that to help explain that and make it happen will be important. The other thing I think might turn out to be very interesting is picking up on these polygenic risk scores that Paul was talking about. I was wondering whether we ought to be looking at women in pregnancy who get either hypertension, PET, or proteinuria, and seeing whether they have polygenic risk scores that are similar to the ones for cardiovascular disease or hypertension, because they do go on to develop those illnesses, and whether we should actually be screening pregnant women so we move in early if they've got those problems, and whether that would be doable. So I think, it's a question of thinking about what is out there and how does it apply to your area, and then persuading people to let you do the research to see if it has a value or not. And I bet most times it will have a value.
Yeah, fantastic. That's the one about preeclampsia and sort of high risk spotting cardiovascular disease early in life is a particularly telling one. I know if you've had severe preeclampsia, as I did with my first pregnancy, it increases your risk of cardiovascular disease, or rather reveals your risk of cardiovascular disease to be raised by really huge, sort of over tenfold. So there's definitely opportunities for that sort of thing.
Yeah, before you got it, and to treat you so you weren't so impacted might well have been a good move.
All these things becoming possible. Right, we've got lots of questions, and of course we're starting to run out of time. So I fear, and some gratitude for the good answers people have received so far. I fear we won't be able to address them all, but there's perhaps a good one here about equity and how can we make sure that all different populations get benefits from genomics. Really hard one for the panel perhaps to wind up on.
I mean, maybe I'll make a start on that. So there's kind of equity within, say, within the UK and trying to limit disparities, but there's also equity on a kind of more global scale. And obviously, given the nature of this group, it's perhaps the global issues that people are thinking about. And of course, currently, a lot of genomic medicine and the early days of genomic medicine really is stuff that's kind of affordable by the few, on a global scale. And actually, you might reasonably argue that I think we'll take the infectious disease example out of the equation, because there I think there is a need globally for genomics. But in sort of non-communicable disease genomics, I think there are a lot more simple things that could be implemented worldwide to improve health outcomes for less advantaged populations long before you start doing genomics. One of the very specific examples of the inequity that's already arising is that, for example, polygenic risk scores, most of them that have been developed so far have been developed in European populations, and their transferability to populations in Asia, South America, Africa, that is not clear. And so even if there were very clear pathways to clinical translation, those pathways might be okay for the NHS, but they wouldn't necessarily work in South Africa or in India or in other countries with a different population ancestries. So there are issues around equity for sure when we think about genomics.
Thank you. Yeah, I think there is increasing recognition about the need for suitable population diversity in data sets if you're going if you're using data to then build something that's for use in a population. Is the data it was built upon representative of that population? So I think you've managed to answer sort of 2 in 1 there, Paul, which is particularly helpful. Did anyone else want to comment on the equity issue before we come to a close?
Only to say that I've already mentioned that sequencing is going to be important for vaccines for COVID-19, but also, if we could actually get sequencing really rolled out across the world, it would have many other utilities, particularly, for example, with multi-drug resistant and extremely drug resistant tuberculosis. There are some molecular methods that help you get part of the way, but not the full way. And there are other things that we could start to tackle more effectively if we had sequenced data readily available for personalized treatment. And so equity is a real issue in relation to access to pathogen sequencing.
But broadly, boosting genomics and sequencing kind of around the world would actually have benefits for even countries where we're quite advanced in our own genomics, presumably in the sort of infectious diseases, particularly not having borders. And,
everybody could benefit from it.
Antimicrobial resistance.
Yes, same. Absolutely, yes. I mean, we haven't talked much about antimicrobial resistance, but quite clearly it's a very quick way to find out what genes are there that are encoding drug resistance, and having the genome data also allows you to look at patterns of transmission and spread and so on. So, so yes, everybody needs pathogen sequencing, and it's becoming easier and easier to do over time. And so one hopes that moves will be made to democratize it, not just in the country, but across the world.
Superb. Thank you very much. Well, I'm conscious of the time. I think it only remains for me to say an enormous thank you to these three super expert speakers who've shared so much really valuable information with us today, and to pass back to Tara and Lydia as the organisers.
Very much, Dr. Brice. Yeah, that concludes our panel discussion and Q&A this evening, everyone. And I'm sure you'd all like to thank me, to join me in extending a huge thank you to our wonderful panelists. It has really been such a privilege to have you all share your expertise in this really exciting field with us, and for giving up your time this evening. And I'd also like to extend another massive thank you to you, Dr. Brice, for moderating such an interesting discussion this evening. And thank you also to all of you for coming along, especially so close to the end of term. If you'd like to leave us some feedback, we'd really appreciate it. I've just popped the form in the chat there. And do sign up to the Students for Global Health mailing list and follow us on social media to hear about future events. But yeah, thank you so much, everybody. I'm going to stay on the call for a bit so people can get the feedback form, but feel free to leave whenever. Tara, I'll just pass over to you.
Yes, thank you all so much. I know I learned so much from the panel, and I'm sure I'm speaking for many of the people on the call. Thank you all so much. This is much better than I would have ever dreamed of. So that was lovely.
Thank you so much. Thank you for having us. Thank you so much.
Yep, I echo that. I learned things, and it's always good to talk to our students. So great. Thank you very much.
Thank you. Bye-bye.
Yeah, sorry we didn't get time to answer or try and answer all of your questions. There's a lot of really interesting questions on there that we didn't even mention. Thanks.
Bye.